Hi guys, welcome back. The next topic we're studying is Myasthenia gravis, and you would be aware that the legendary actor in Bollywood, Amitabh Bachchan, suffers from Myasthenia gravis. Having said that, I would just like to remind you that the pathophysiology behind development of this disorder is autoimmune. And the thought process on reading the word autoimmune is that the MCQs are always going to describe a young female in the reproductive age group. But make no mistake, the gender ratio for Myasthenia gravis is 3 to 2. That's for every 3 female patients, there would be 2 male patients, and therefore a large number of questions that have been asked on this topic in the previous years have deliberately begun by describing a male in 50 to 60 years of age. From the prevalence perspective, this disease is usually common in women between 20 to 30 and in male patients between 50 to 60 years of age. And the autoimmune damage would be occurring at the neuromuscular junction, and therefore this would be taken as an example of a post-junctional defect. In the later part of this particular video, I'll be speaking regarding Lambert-Eaton syndrome that's associated with lung cancer, mainly small cell cancer of the lung, and that's an example of a pre-junctional defect. Even botulinism is an example of a pre-junctional defect where the amount of acetylcholine produced at the neuromuscular junction is relatively lesser. But in myasthenia gravis, the problem is not with respect to the amount of acetylcholine. It's mainly going to be related to the receptors. So the first and the foremost thing that you can see in this line diagram, the blue representation has been shown to be relatively lesser. The blue representation is for the acetylcholine receptors, and these acetylcholine receptors at the post-junctional membrane, the physical amount of it or the total number of these receptors at the postsynaptic membrane in myasthenia gravis from the pathology perspective are shown or are present relatively lesser. So I can say overall the efficiency of neuromuscular transmission is getting hampered. Second, if you look at the white representation, I can draw parallels with like we read in celiac sprue that there is a flattening of the mucosa. That's because of the antibodies. Similarly, in the same spirit here, I'm saying that the antibodies which are produced would contribute to damage to the postsynaptic membrane. And as a result of it, the white representation in this case is showing that there's going to be a flattening of the postsynaptic membrane or postsynaptic folds. And therefore, having said that, combination of point number 1 and 2 will contribute to a decrease in the efficiency of neuromuscular transmission. And to explain this, I can go into a bit of physiology as well. If you read about the acetylcholine receptor, then acetylcholine receptor will be having total of 5 subunits, which are named as alpha, beta, gamma, delta, and epsilon. And especially the alpha subunit is what you need to remember, because acetylcholine binds to this alpha subunit of the acetylcholine receptor. The red dot is acetylcholine, and it is binding to blue, which is the receptor, and this receptor has 5 subunits. We are focusing on one of those units, that is alpha, and the activation of this alpha subunit then causes sodium to go inside the muscle, and therefore there is a membrane depolarization and the muscle tends to contract. Now what happens in myasthenia gravis is that this main unit on which acetylcholine will act, listen to this part carefully. I said there are 5 subunits of acetylcholine receptor, and it is the activation of the alpha which results in sodium influx into the muscle. Now imagine there is an antibody which is shown in green, and that is physically gonna block the alpha subunit of the acetylcholine receptor, and therefore if you block alpha, then sodium influx into the muscle will not happen, and therefore the muscle weakness component can be explained in this case. So what I mean by decreased efficiency of the neuromuscular transmission implies acetylcholine will activate the receptors, but in this particular case the main subunit of the acetylcholine receptor is physically blocked by the antibody. Therefore there's a decreased neuromuscular transmission efficiency. And over and above this, the last point to be remembered from the pathophysiology perspective is an exaggeration of what happens normally. You see, even when you keep on, if you're working out in a gym, gradually your muscles will get tired. In myasthenia gravis, due to combination of all the points that I've written as 1, 2, and 3, the presynaptic rundown, meaning of the word presynaptic rundown is that the amount of acetylcholine that is released per impulse, because every stimulus is going to cause a fresh amount of acetylcholine or quanta of acetylcholine being released per impulse, then the total amount of acetylcholine released per impulse gradually begins to reduce. And I can say that presynaptic rundown is actually a normal phenomenon. Even when we are doing the same activity again and again, we tend to get tired. But in myasthenia gravis, due to combination of all these factors, which is one, the receptors are relatively lesser because they're damaged. Their active unit is also physically blocked. plus there's a flattening of the postsynaptic membrane. The overall presynaptic rundown, which is a normal physiological phenomenon, is exaggerated. So therefore, due to this exaggeration of the presynaptic rundown, or a combination of all these factors, what we get is a cardinal feature of this condition, that is easy fatigability. I mean, if we are going to do a test in this patient by the name of repetitive nerve stimulation, we're going to find a decremental response. That's again a very good pickup point in an MCQ, because Lambert-Eaton syndrome per se will always say the word incremental response, but in myasthenia gravis, it will always be written decremental response. And I'll just highlight and explain the point of myasthenic fatigue once again. What I'm trying to say here is that the overall functioning at the neuromuscular junction has been affected by the autoantibodies, which have been shown in color green. So now we need to remember the names of those antibodies which are playing the villain role in this particular case. So the first antibody that's going to be seen in this case is having a simple name that would be easier for you to remember as well. That is anti-acetylcholine receptor antibody. This is going to cause damage to the postsynaptic cleft. It's going to block the alpha subunit, plus the total number of receptors available would also be relatively lesser. But then over and above this in the exam, he can also ask you about a second antibody. The name of this antibody is anti-muscle specific kinase antibody. So if he wants to make it easy, obviously the first test that I'm writing is the most specific test for diagnosis of this condition. Almost 85% of patients with generalized myasthenia gravis will be having anti-acetylcholine receptor antibodies. But in some of these patients, there might be another antibody present that is called as anti-muscle specific kinase antibody. And why that is important for you to remember is primarily because, one, what is the function of this antibody, the muscle specific kinase? I mean, antibody is obviously understandable, but what is the function of muscle specific kinase? This muscle specific kinase is responsible for clustering of acetylcholine receptors. It helps in creating that critical mass of acetylcholine receptors at the neuromuscular junction. And if you have an antibody against musk, which is responsible for clustering of these receptors, then the function of this is hampered, and therefore the total density of receptors is lesser. I'll try to explain that again. You see, those acetylcholine receptors need to be expressed at the neuromuscular junction at a particular density, so that acetylcholine, when millions of molecules will be released, they'll stimulate these receptors again present in millions, and thereby the sodium influx will occur and the muscle should be in a position to contract. But for maintaining that particular density of the receptors at the neuromuscular junction, this antibody is playing a spoil sport, and it prevents that clustering or prevents that critical density to be present in the neuromuscular junction, and therefore the efficiency of neuromuscular transmission is reduced. Another reason why you should know about anti-musk antibody is because this antibody, if it is present, you will notice that the response to pyridostigmine is poor. The drug of choice for management of myasthenia gravis, you know from pharmacology as well, that's pyridostigmine. Neostigmine is more preferred in pediatric age group. The drug of choice should be answered as pyridostigmine, not obviously physostigmine, because it will cross the blood-brain barrier and I do not need a central action. I need a peripheral action because this disease is a disease of the peripheral nervous system. So the main point is that pyridostigmine, when is used, you can sometimes have a worsening of the condition of the patient, and the situation where we get a worsening in myasthenia gravis with pyridostigmine, or poor improvement or poor response with pyridostigmine, is due to presence of anti-musk antibody. Most of these patients would be negative for anti-acetylcholine receptor antibody. Remember, as I had figured, 85% of patients would be positive. So a lot of patients who are negative for this one would be having anti-musk antibody, and they might be showing a deterioration to pyridostigmine as well. So that has to be kept in mind. Another antibody which is to be remembered in this case is anti-LRP4 antibody. So a bit of vocabulary which is to be remembered. These are the tests that are most of the time done for diagnosis of this condition. But in the current edition of Harrison, the 21st, he has mentioned again antibodies against a couple of other, I would say, agents which are responsible for clustering of acetylcholine receptors and maintaining a critical density of receptors at the neuromuscular junction. So you also need to remember the following names only for academic reasons. That would be antibodies against agyrin. Again, what is the function of agyrin? Clustering of acetylcholine receptors at the neuromuscular junction, maintaining a critical density, that would be hampered. Then is antibody against netrin 1 receptor. I mean, these would not be available as routine tests, most of the time, maybe research-based institutions, that is okay. But still, because this is given in the newer edition, at least one should read the names here. From the exam perspective, you mainly need to remember the name of these three villains that I'm saying. That is anti-acetylcholine receptor antibody, then there's going to be anti-musk antibody, lipoprotein, LRB is lipoprotein receptor protein 4 antibody. But we also have antibodies documented in this condition against agyrin, netrin 1 receptor, and then Casper 2. Apart from this, another very peculiar data is given. You are aware of titin. Remember, titin is a protein in the muscle. It's called as the spring protein of the muscle. It's one of the largest muscle protein. And in some patients of myasthenia gravis, antibodies have been documented to be present against striated muscles as well. That would imply against the skeletal muscle, because this is a disease of skeletal muscle. Again, what's important for you to know that is because in the later part of this discussion, I'll be talking about dysphagia as a presentation of this disease. On reading the word dysphagia, the impression is esophagus is involved. But no, guys, myasthenia gravis is not a disease of the smooth muscle. It's a disease of the skeletal muscle. So in this condition, we are also able to document anti-striated muscle antibodies, which are directed against titin. And what is titin? It's called as the spring protein. It is gonna be also the largest protein in the muscle, and this would be affected. The inferior 2 points are only for academic reasons that I am discussing. Otherwise, from the exam perspective, it's the top three names that I want you to remember. And due to these villains, as I've explained, if you are going to do electrodiagnostic testing in these patients, electrodiagnostic testing would mean tests like a repetitive nerve stimulation test. Then the keyword on repetitive nerve stimulation test in an MCQ would be decremental response. Most of the time in the MCQ, to make it sound sophisticated, he will use words like low frequency stimulation produce a decremental response. It simply means the fact that if you are gonna be stimulating a nerve again and again, the muscle will have to contract. But because the efficiency of neuromuscular junction is lesser, as I said right in the beginning, the presynaptic rundown, which is a normal phenomenon, is exaggerated. The acetylcholine release per impulse is relatively lesser. So overall you would be having a poor performance of muscles. And usually the muscle that is involved in this condition are one of the powerful muscles. Like I can say that the number of times we blink per minute, it remains constant. If you're watching a video for a long duration, maybe your blink rate would be lesser and your eye might feel a little dry, but the number of times we blink every minute is going to be constant. But in myasthenia gravis, the muscles of the eyeball, especially extraocular muscles, are the ones which are impacted, which is why most of the time one of the early manifestations that will be described in MCQ from the clinical perspective would be development of ptosis and diplopia. And also you will notice that in these patients, the ptosis is going to be asymmetrical and will also be having a diurnal variation where the symptoms may not be present in the morning hours, but these symptoms will tend to be triggered, or they would rather come in when the person will be using the muscles. Like for example, if this lady with myasthenia gravis, she's watching a video on a mobile phone, or if she's watching television, or like if she's working on a computer, or she's playing a video game, on repetitive usage of eye muscles, like your eye muscles would be doing saccadic, will contribute to helping in generating the saccadic movements and following object when you're trying to play a video game. So during that particular point of time, symptoms of these patients would be present. And then the question will also say that if you ask this patient, what do you do when you have this double vision? She says, sir, I just close my eyes, I sleep, I give rest to my muscles, and that's when the symptoms are gonna decrease. So either giving rest to the muscles or sleeping will cause physical improvement of symptoms in these patients. Again, I would like to highlight decremental response, diurnal variation neurological symptoms, and specifically if he mentions in a male patient 50 to 60 years of age, deliberately is not introducing a young female. He thinks he'll try to confuse you. You won't be, because I give example of Amitabh Bachchan there, and then he can ask you regarding the testing that we would be doing for this condition. But before we go into the testing, let me now enumerate on the subsequent slide how in the question the clinical manifestations would be described. This autoimmune disorder, like any other disease, will be having that standard phases of exacerbations as well as remissions. And if these patients will develop any intercurrent infection, like myasthenia gravis case ended up with COVID-19, then they can be worsening of this situation as well. Like a myasthenia gravis patient was pregnant, and then during pregnancy she suffered from an infection. It may not be COVID, it could be any other infection like a UTI, but then her myasthenia gravis as the disease can worsen to the level that she might even be requiring ventilatory support. That is development of myasthenic crisis. Myasthenic crisis is mainly going to be managed with the intubation or ventilatory support in this case. So exacerbations will be present. You most of the time it's going to be intercurrent infection that can contribute to worsening. Anytime you are having a ventilator requirement in a myasthenia gravis patient, that implies that there is a myasthenic crisis happening. So the question will most of the time, as I sensitize you, will begin by describing a 20 to 30-year-old female, or might begin by describing a male who's between 50 to 60 years of age. And most of the time the complaints is that they get tired very soon. Initially the symptoms may be very non-specific, that is weakness and easy fatigability. Both of these should be remembered as cardinal features for the diagnosis of this condition. Just like when I was describing Parkinson disease to you, I was talking about cardinal features in the form of trap, that is tremors, rigidity, then bradykinesia, and then postural instability. In a similar spirit, what I'm trying to explain is the weakness in the fatigability component, and that tends to increase. I mean, there's a substantial increase in this weakness with repeated use during the day. So the diurnal variation part would be exaggerated. In fact, two medical disorders where diurnal variation neurological symptoms would be highlighted. One of them is Lambert-Eaton syndrome. In Lambert-Eaton syndrome, you will notice that after doing exercise, the symptoms of the patient will become lesser. But here, what will happen is that the symptoms of the patient will worsen. So there is a myasthenic fatigue, as I was saying, or the weakness of fatigability increases with repeated usage. If the question says opposite, that the weakness reduces, that's the key word. If the weakness reduces with repeated usage, then think in terms of Lambert-Eaton, and I'll keep on giving you pointers with respect to how would you pick up in an MCQ myasthenia gravis versus Lambert-Eaton. The first feature for this particular case, as I was saying, would be developmental double vision. I mean, the symptom that would come up in these patients is diplopia. This diplopia is occurring because the person is suffering from ptosis, and you will notice, like in this image or diagrammatic representation as well, that the ptosis is not symmetrical. Had the ptosis being symmetrical, then you would not have any double vision in this condition. It is the asymmetrical ptosis which explains the development of double vision, because our both eyes will be forming. I mean, we have a binocular vision, right? So the image of the right and the left eye in the brain will superimpose and we get a binocular vision. But in this case, one eye would not be able to see properly because of the drooping of the eyelid. So ptosis, which is asymmetrical, will explain the development of double vision in these patients. Most of the time, if you ask these patients to look upwards, like you and me can look up, down, sideways as long as we want. If you request these patients to look upwards, sustained upward gaze, then there can be a development of ptosis. What I mean by sustained upward gaze is, like if I'm looking up, like my commands to the patient will be look up to the roof of the clinic. So you will notice that in a normal individual, we can look up and down and as long as we want. But in patients of MG, you'll notice sustained upward gaze can trigger development of ptosis in a very short period. Most of the time, the ptosis can be triggered in as little as about after 30 seconds. That's what is also referred in books as Simpson's test, though it's not a very reliable and a very reproducible feature. So I would not like to give specific importance to the word Simpson's test per se. I just said it verbally. There's no need to note it down, Simpsons. But yep, this finding that I've described, that ptosis will be triggered after 30 seconds of looking upwards to the roof of the clinic. This finding may not be replicated, or it may not be reproduced every time you're gonna do this activity. Because if person has taken medication, or if the person has slept well, or person comes in the early morning hours, then because at that point of time the functioning of the muscles will be relatively better, so you may not be able to appreciate this finding of ptosis developing a sustained upward gaze in early morning hours. But yes, you would be getting it when there is going to be like a late evening presentation, and patients are obviously not always going to come to you as a late evening consultation. It can be a early morning consult also. So at that point of time, the key word that you need to pick up is in the MCQ is that watching TV or like working on a laptop, or like she's a computer professional and she's not like playing a video game, but she has to, type on a computer, or she's a call center employee. So her eyes have to be glued onto the screen so that she can go about her daily tasks. And or she's like working from home, and that's when she's having this double vision, and she thinks that it's some kind of a refraction issue. And when she comes to you, she says, I watch TV, and that's when, or I work on a laptop and I start getting double, or I'm not able to see the field of vision as well. The third feature that you will notice in this patient will again be very peculiar, which is that if you ask this person to smile, you see, when you and me smile, then our lips will curl upwards. I mean, we may not have dimples, but then when we smile, every time we look at a smile, our lips will tend to curl upwards. But in myasthenia gravis, because of this muscle fatigue, you can see when you are requesting the person to smile, you are noticing that the teeth of the patient are becoming visible. It's like somebody's angry, right? The central part, the lips are like they are spreading in this particular case. So the manifestation that is being represented in point number 3 of this discussion is referred to as snarling faces. Again, that's not a very reproducible finding all the time, and it may not be a very reliable feature as well. But if this is given in the MCQ, then that gives more credibility to the diagnosis of this condition. The first aspect to be remembered for this condition is diplopia and ptosis, and then is the manifestation of worsening of the symptoms with repeated usage, or more symptoms seen on later part of the day, or with respect to worsening of symptoms with exercise. The next thing that would be described in this MCQ would be difficulty in chewing and swallowing. You see, especially when this person is eating non-vegetarian food items, because they're more chewy, I would say. Like if you're eating meat, for example, or eating mutton, that would be more chewy as compared to chicken, and or both of these would be much more chewy as compared to paneer, for example. So the complaints of this patient is that I am the first one to sit on the dining table, but I am the last one to get off it. And it's not that the patient is eating more, rather this patient says that I'm a very slow eater, because the person will have to chew food for a relatively longer duration. Patient will get tired also, so she'll eat for a short duration, then give rest to her muscles, then chew again. So that's the reason why it will take a relatively longer time for these patients to finish a meal as compared to a normal individual. And it's not only about chewing, there is a definitive tongue weakness also experienced by these patients. Because of this tongue weakness component, what you have to understand is that the speech of the person will be affected, plus the tongue and the palate plays a role with respect to swallowing also. So lots of time the complaint that could be described in a question could be even in the form of nasal regurgitation of fluids. I saw two aspects. One, I said that tongue plays a role with respect to swallowing, so that's why dysphagia component can occur. And while I'm writing this dysphagia, I would like to clarify once again that on reading the word dysphagia, the impression that comes is that there is going to be a problem with the esophagus, but esophagus is a smooth muscle, and this is a disease of skeletal muscle, no? So that's why I've clarified this would be oropharyngeal dysphagia. And apart from this, another feature that would come because of tongue weakness would be dysarthria. That would be unclear speech or a mushy speech. And this is important for diagnosis as well. Like in these patients, when you do a hydrophonium test or a tensilon test, and you will notice that before giving injection of hydrophonium, when you are asking the patient to speak continuously, the speech will become unclear. But in the same patient, after giving a shot of tensilon, giving a shot of hydrophonium in the tensilon test, because hydrophonium will be a short-acting anticholinesterase agent, so it will prevent the breakdown of acetylcholine. Acetylcholine will be able to stimulate or will be able to act on the receptors for a longer duration, and therefore the strength of the muscles will increase, and therefore you will notice that the unclear speech of the patient will suddenly become clear. The ptosis of this person will practically disappear. So I'll describe the tensilon test to you as well. But here I just want to bring to your notice that dysarthria, I mean, a lot of features that would be given in this MCQ will begin by saying diplopia, or we'll talk about difficulty in swallowing, or he'll talk about difficulty in speaking. And that difficulty in speaking is mainly coming because tongue also plays a role in speaking. Lots of times some alphabets when we speak, our tongue touches the hard palate. So that would not be happening. Therefore, pronunciation of certain alphabets would be defective in these patients. So sometimes he will write words like mushy voice, M-U-S-H-Y, mushy voice, or he might write the word dysarthria. Then because of the palate weakness that is coming up, these patients might be having nasal regurgitation of fluids. You see, there is a possibility that sometime in your life you were drinking water and your brother or sister suddenly made you laugh. It can happen, no, that if you're drinking something and somebody makes you laugh, water can come out of your nose. That can happen with anybody. But in this person, like this young lady, she says, I was getting ready for my office, I was late, and she was trying to drink milk fast. Like we can drink milk or juice fast, but for these patients, one, that gulping activity, drinking anything fast would be little difficult. And lots of times she says, if I try to drink fast, like I was late for my office and I don't know what's going on, it came out of my nose also. So nasal regurgitation of fluids can occur. And the same patient, if there is gonna be a myasthenic crisis, remember myasthenic crisis is worsening of the disease, usually due to intercurrent infection, can be seen commonly in pregnancy as well. That is when the aspiration risk in these patients will also be increased. So as far as the aspiration risk is increased, that's not a routine feature. The aspiration risk that I'm writing, I'm just like to put it in a dotted fashion here to say that this would not be a routine presentation of these patients. Only on severe deterioration like going into myasthenic crisis, the aspiration risk would be increased, but nasal regurgitation of fluids would be a rather relatively more common manifestation. Over and above this, bulbar weakness will be seen in these patients. For bulbar weakness, I'm talking about cranial nerve number 9, 10, and 12. And therefore, like we read about bulbar palsy due to stroke. Similarly, bulbar weakness is what I'm describing for these patients. But yep, as far as reflexes are concerned, reflexes are preserved in myasthenia gravis. In bulbar palsy, the gag reflex would be gone, cuff reflex would be gone. In these patients, if it's a crisis, obviously the reflexes would also be lost. But routinely in myasthenia gravis, we will not say gag reflex is absent. Reflexes would still be very much there. But apart from this, muscle weakness can be present, which could result in the manifestations that I have explained. Now, a large number of these patients can be having even arm weakness as well. And most of the time, it's the shoulder girdle muscles that would be affected. Most of the time, we use shoulder girdle muscles to, comb our hair, or like if you have to retrieve something from a shelf, like you're working in a kitchen and you're doing some cooking for yourself. So we might be keeping spices in a small almirah in the kitchen, slightly at a higher level that our as compared to our visual field. So when you have to raise your arm, and pick up some masala while you're making tea for yourself, and you want to put tea masala into tea, you will be using your shoulder muscles. So that's when even shoulder muscle weakness can be present. So proximal weakness of the shoulder girdle can be present, and it can be asymmetrical as well. Like I was saying, there's a asymmetrical ptosis in this condition. Similarly, like in one shoulder, the weakness can be more as compared to another. In fact, while testing these patients, you can ask these patients to do an arm abduction, or you can ask them to elevate both their arms, and you will notice that if, like, obviously if you keep your arms elevated for a very long duration, like if you have been punished by your teacher at school time, possibility your arms would get physically tired and they're aching. But in this person, the manifestations would be coming, the weakness part would come in much more earlier. So proximal asymmetrical limb weakness and shoulder girdle weakness can also be described in these patients. Traditionally, we read about like proximal limb weakness with respect to dermatomyositis or polymyositis, but there you will notice it would be a symmetrical weakness present. In this case, it's a proximal asymmetrical weakness. So that word has to be remembered: asymmetrical ptosis, asymmetrical limb weakness, that can be described in these questions. Then, as I said, a couple of these patients can worsen as well. There is a high probability that our case can go into diaphragmatic paralysis. Therefore, this is itself a question that what kind of respiratory failure would be seen in this case. Your answer would be type 2 respiratory failure, because diaphragmatic paralysis will cause a buildup of carbon dioxide. It will cause respiratory acidosis. It will cause carbon dioxide narcosis in these patients as well. And therefore, ventilator assistance would be required. If he says, what is the first line treatment for myasthenic crisis, your answer would be intubating the patient. And that's the initial approach. Though the drug of choice for myasthenic crisis will be answered as intravenous immunoglobulins. No, do not answer as steroids. The drug of choice for myasthenia gravis I'm mentioning here only. The first step is obviously securing the airway, but then intravenous immunoglobulins are the mainstay of treatment for these patients. I mean, first, don't answer steroids. We use steroids in myasthenia gravis, that is okay. But for myasthenic crisis, because that's a worsening that is seen lots of times seen in pregnancy, could be due to intercurrent infection. On a comparison basis, intercurrent infection is a more common cause, and that's where we will have to, aggressively manage these patients. Intravenous immunoglobulins, traditionally we read with Kawasaki disease. Intravenous immunoglobulins we read with Guillain-Barré syndrome, but then we read it even with myasthenic crisis as well. And the point next that I'm writing is one of the good pickup points in an MCQ, that he'll keep on saying the word weakness, weakness everywhere. But when you're going to check out the reflexes of these patients, the reflexes will be normal. And why this is important is because when we will discuss Lambert-Eaton syndrome, I will still talk about weakness in this condition, almost identical to what I've discussed in myasthenia gravis, but their reflexes will be affected, or reflexes would be depressed, or there would be areflexia, because acetylcholine there is gonna be less, so reflexes would be affected. Here acetylcholine amount is normal, it's not able to act, that is okay, but then still some partial action is occurring. So most of the time in these cases the reflexes will be normal, whereas when it comes to prejunctional defect, because acetylcholine deficiency is there, so areflexia or hyporeflexia can be present in these cases. A large number of questions that can be given in the exam might be having only extraocular muscle weakness. In those circumstances, if extraocular muscle weakness is present consecutively for 3 years, I would also like to do a MRI to rule out local causes that could be causing involvement of the oculomotor nerve. Is normal, MRI brain is normal, and extraocular weakness is persisting for 3 years, then I'll be using the term ocular myasthenia gravis. The treatment strategy for ocular myasthenia gravis is slightly different from that of generalized myasthenia gravis. So if I'm having all the 9 points that I've described at the moment before you, then I'll say generalized variety of myasthenia gravis. If I have only ocular complaints, if only I have this presence of diplopia and ptosis, then I'll say ocular myasthenia gravis. But obviously before I say myasthenia gravis, I will have to do imaging in this particular case. I mean, the imaging that will be done is to rule out local causes of involvement of the oculomotor nerve. So MRI brain must be done before we think in terms of or writing the diagnosis in the form of ocular myasthenia gravis. For point number 10, what I would like to say is that the antibody which is present in this condition, the villain antibody, right? I told you 3 of them. Anti-acetylcholine receptor antibody is immunoglobulin G class, and you know that IgG class of antibody can cross the placenta, because we were talking about a young female in a reproductive age group. So there's a possibility that the antibody will go from the body of the mother to the baby. Very peculiar, because normally hepatitis B goes from mother to baby, HIV goes from mother to baby, infections go from mother to baby. I'm teaching a non-communicable disease that can affect the baby of this child as well, and therefore the child will suffer from neonatal myasthenia gravis. As a result of this neonatal myasthenia gravis, the child might be one having failure to establish respiration. Therefore, we should always ensure that institutional delivery will occur in this case. Otherwise, if the child will not breathe after birth, they can be birth asphyxia and development of hypoxic ischemic encephalopathy. So the delivery should be occurring at a good hospital. And let's assume that the pediatrician has taken good care of the kid, but still subsequently there is bound to be breastfeeding problems. Why breastfeeding problems would come up is because the tongue of the baby plays a very important role when it comes to doing suckling, swallowing, and breathing. You see, a baby when he is breastfeeding, he has to suckle also, he has to swallow also, he has to breathe also. So the tongue plays an important role, and if the tongue is gonna be weak, so no big deal that nasal regurgitation of feeds can occur, and a possible aspiration can also occur. And therefore, we'll be telling the mother that we'll be prescribing some drops to your child. You need to give these neostigmine drops on a regular basis so that your child is able to feed. And if you give you give a feed to your child without giving neostigmine, then possibility of aspiration cannot be ruled out. So the mother is happy that, okay, you are giving some treatment, but at the same time, she's saying, sir, are you serious? I mean, you mean that my kid would be on medication? You've given drops at the moment, maybe you'll change it to a syrup or a liquid formulation. But she says, are you serious? I mean, you expect me to give this medicine to my child for whole of his life? So I tell her, ma'am, that please don't worry, because the antibody in this particular case is immunoglobulin G class of antibody, which has a half-life of about 3 weeks. So after 3 weeks, this antibody will be cleared by the immune system of the baby. See, the baby is not having the disease. No, his immune system is okay. He passively acquired the antibody from the mother, and this antibody will be cleared by the immune system of the child, because of which I'm interposing a word in this case, which is neonatal transient myasthenia gravis. What I mean by word transient myasthenia gravis is that because this antibody will be cleared by the immune system of the child, therefore after 4 weeks there is no need for any medication. It's only the first month where medication would be given, a first month of life of a child. after 4 weeks, usually there is no need for any medication to be given, because every antibody has a half-life. So this antibody will also be cleared by the immune system of the kid, and therefore the child will recover, and there would be no need for any medication, which is why the term is neonatal transient myasthenia gravis, and MCQ will say it as a good prognosis. After saying bad things like not being able to breathe and aspiration, when I say good prognosis, I start getting a flurry of messages that, sir, how is it possible? On one hand, you are saying that there is going to be aspiration risk. On one hand, you are saying the child will not be able to breathe. And then you say it's a good prognosis. Yes, guys, good, because after 1 month of life, child is not going to suffer from this. It's only the first month of life which is critical, but after that, the child is not gonna have, or gonna is not gonna suffer from these manifestations. So I can say that pregnancy can be a tough time for a lady with myasthenia gravis, in a sense that she can go into crisis, especially if she develops an intercurrent infection like UTI can occur in pregnancy. Due to change in the curvature of the urethra, ascending infection can occur and cystitis can occur, and then there can be a possible risk of even a complicated UTI in the form of pyelonephritis. So considering that in pregnancy anyway infection risk is increased, especially genitourinary infection risk is increased, there can be deterioration in these patients. If he says what is the first thing to be done, he can give you a ABG report. You'll say that if PO2 is less, PCO2 is elevated, I'll secure the airway. But then subsequently intravenous immunoglobulins would be the mainstay of treatment for crisis. Though if he says myasthenia gravis, then it's okay. Pyridoxyticmine will be the approach. We'll plan a thymectomy for these patients, and that's again a very interesting fact that I said right now, that why would we plan a thymectomy for this patient. And for this I would like to go back to one of my previous slides where I described these, the jokers there, the three antibodies, the villains are the ones which I described. Lady, she's an educated one. Let me say she's not a doctor, but she is educated enough to understand that there are antibodies. She understands the meaning of the word autoimmunity, antibody against self. So she's asking you, I mean, these research-based antibodies were for academic reason, but the routine test that you write, right? Patient can read English and can, read words like anti-acetylcholine receptor antibody. So person is asking you that, this lady is asking you, doctor, why am I having this? So you would tell her that, ma'am, 75% patients of myasthenia gravis tend to have thymic abnormality. Out of this 75%, I would like to tell you that almost 65% cases of myasthenia gravis would be having a thymic hyperplasia. So thymus is the villain which is responsible for production of these villains. In about 65% cases of myasthenia gravis, there's a thymic hyperplasia. In about 10% of cases, there would be a thymoma present. And thymoma, anyway, though it's the tumor will not be life-threatening in a sense that it's not a malignant tumor, but it will still be having a mass effect in depression, recurrent laryngeal nerves, so surgical intervention would be required. You see, in a large number of MCQs of myasthenia gravis of the generalized variety, the treatment of choice will be asked to you, and there do not answer either steroids or immunotherapy, do not answer pyridoxyticmine. You will answer thymectomy. Why? Because thymus is a villain that is responsible for these manifestations. At this junction, I also want to tell you that in the thymus, we have special cells present which are called as myoid cells. And these myoid cells express in the thymus, there is presence of what is called as myoid cells, and these myoid cells are the ones which express acetylcholine receptors, and this is where the antibodies are gonna be attacking the self. I mean, what I'm trying to say is that the thymus would be having myoid cells which express acetylcholine receptor, and then this thymus would be producing autoantibodies against self. I'll repeat the fact once again. What is that autoreact? He can ask you that the antibody which is produced in this condition, the anti-acetylcholine receptor antibody, this initially, I mean, how the thymus is getting sensitized and is producing this antibody? Then thymus contains myoid cells, and these myocytes, they tend to express this antigen. And in case thymus is having a hyperplasia or thymus is having presence of a thymoma, then it will start producing antibodies against this antigen which is present, and unfortunately this antigen is present at the neuromuscular junction all over the body. So it's an example of a misdirected immune response. The immune system is tending to attack self. So they, like, in rheumatic fever, why I explained that is, like, in rheumatic fever, I have talked about M antigen on the bacteria, and then I said antibodies will cross react. So there it was easier to understand because it was the infection coming from outside. But in myasthenia gravis also, I mean, antibodies are being produced from with help of thymus. That's understandable. I mean, thymus abnormality is responsible. That's understandable. But then why are they attacking only the acetylcholine receptor? I mean, there are so many receptors present in the body, no? So only anti-acetylcholine receptors are being attacked. That's because the antibodies have been sensitized against this receptor, which is expressed on the myeloid cells in the thymus itself. And normally, your and my immune system is such that though this antigen is present on the myeloid cells, our thymus is gonna produce a check control, and the auto antigens or the antibodies against the self antigens would not be produced. But in a setting of hyperplasia or thymoma, this check is lost, and therefore antibodies against these receptors would be formed. These antigens would be formed, and then I said this antigen is present on myeloid cells. The same one is present all over the body, and that's when all hell break loose, and then manifestations of repetitive nerve stimulation showing a decremental response will be produced. Next up, we're going to talk about workup of these patients, where first I'll talk about a very interesting test for diagnosis of this condition that is called as IcePack test. In earlier times, we straight away used to do a test by the name of Tensilon test, but now Tensilon test is reserved only for those cases which are difficult to diagnose. Nowadays, we do not start with Tensilon test, but we can do a IcePack test, which is easily reproducible. If I zoom into this image, you can see that this gentleman is having ptosis, and then what we're doing is applying a simple ice pack like the one that comes with vaccines, and you're noticing that the ptosis part is disappearing. So it looks very surprising, but let's look at what is happening. See, once acetylcholine binds to a receptor, then there is an enzyme that is responsible for degradation of acetylcholine by the name of acetylcholinesterase. And you are aware of the fact that all enzymes are temperature dependent. The activity of every enzyme is temperature dependent. All enzymes optimally work at 37 degrees Celsius. If you decrease the local temperature to less than 37 degrees Celsius, then the activity of this enzyme will be lesser. If you decrease the activity of this enzyme, then the amount of acetylcholine at the neuromuscular junction, I mean, whatever acetylcholine is coming and is binding to those receptors, whichever are left at the blunted postsynaptic membrane, the total duration for which acetylcholine will be able to act will be relatively exaggerated or will be relatively increased. I'll say the fact once again. I said if you inhibit the degradation of acetylcholine, then it will be able to stimulate the receptor for a longer duration. And if you are able to stimulate a receptor for longer duration, the twitch duration will be increased. And if the twitch duration is increased of myofibrils, the performance of muscle will also increase. And you can notice that the ptosis of this patient has surprisingly disappeared. I mean, this is a non-invasive test that we can be doing for diagnosis of myasthenia gravis. It does not entail giving any injection to the patient. All you are doing is decreasing the local temperature, decreasing the activity of the enzyme that breaks down acetylcholine. And if acetylcholine is able to stimulate a receptor for a longer duration, agreed that the total number of receptors are less, agreed that the postsynaptic membrane is gonna be flattened, agreed that the efficiency of the neuromuscular junction is lesser. But what I'm trying to do is I can't be God and I can't increase the number of receptor. I cannot repair that flattened postsynaptic membrane, but at least what I can do is I can use physiology to my advantage, that if I am able to increase the twitch duration by inhibiting the breakdown of acetylcholine, therefore the strength of the muscle will increase. So IcePack test is one of the initial tests that can be used for diagnosis of this condition. It would be a non-invasive test that can be done. And let's look at now a couple of blood work that would be required along with some specialized tests. The blood work that would be required would be to pick up this antibody. That was the first thing that I said in the villain perspective, anti-acetylcholine receptor antibody, which would be checked by radioimmunoassay. And in almost 85% of cases of generalized myasthenia gravis, this antibody would be present. This is also found in 50% cases of ocular myasthenia gravis. These figures are to be remembered from MCQ perspective, that generalized G is generalized myasthenia gravis. 85% of patients would be positive for this antibody, and 50% of cases of ocular myasthenia gravis would be positive for this antibody, which implies the fact that no big deal, that this test can turn out to be negative as well. If it turns out to be negative, no problem. I still have a backup. No, I was speaking about a couple of other tests also available. Like I can be testing for anti-musk antibody, I can be testing for LRP4 antibody. So even those names of antibodies have to be remembered. And this is a specific test that can be done in this person and is a direct evidence of the autoimmune, I would say, etiology behind the development of this disease. The subsequent test that would help in diagnosis is electrodiagnostics. The electrodiagnostics would imply deployment of a repetitive nerve stimulation test. And when we do this repetitive nerve stimulation test, we can do stimulation at various frequencies. And most of the time, you will notice the question or the examiner will himself help you. I mean, when it's a two or a three-liner MCQ, there will always be a keyword in the MCQ given. And if he wants a diagnosis of myasthenia gravis, he will have to give it. Decremental response would be seen on repetitive nerve stimulation. The magnitude of this decremental response of more than 10% decrease at a frequency of 3 hertz stimulation. I mean, the frequency that I'm saying is the number of times we are stimulating the nerve. And at this low frequency of 3 hertz, we find and get a decremental response. It's not important to remember the frequency. It's not important to remember the percentage of the movement. The key word is myasthenic fatigue is characterized always by decremental response. The presynaptic rundown, which is a normal phenomenon, is exaggerated in these patients. Now, he would love to ask at this moment what is the best test for diagnosis of this condition? What is the investigational choice? Investigational choice is the one which is sensitive also, most sensitive and most specific also. So if he says what is the investigational choice for diagnosis of this condition, then our answer would be given as not hydrophonium test. Do not answer tensilon test. That's what we carry an answer from pharmacology. I'll talk about tensilon test also. Your answer would be single fiber EMG, single fiber electromyography. And lots of time this facility may not be available at a government hospital. That is why I wrote repetitive nerve stimulation first. But that does not mean that that is much more, I would say, reliable for diagnosis. It is single fiber electromyography, which would be the most reliable test for diagnosis. And the technical words written in the electromyography report would be blocking and jitter, which are, I would say, English expressions for again a decrease in the performance of the muscle, or like the a decremental response thing. The same thing to be made more sophisticated would be written as blocking and jitter. Then in case, let me say, this antibody test is turning out to be negative, repetitive nerve stimulation test is inconclusive, like you are not getting a 10% decrease, you're getting maybe a 3%, 4% decrease. And single fiber electromyography either is not available, or even if it is available, again is giving equivocal results. In those circumstances, he says we can do a hydrophonium test in the patient. In hydrophonium test, what we're gonna do is that, because this is a short acting anticholinesterase agent, the onset of hydrophonium, like if you give this injection hydrophonium, it will start acting after 30 seconds only. And then I mean, the peak effect of this would start coming by approximately 5 minutes, and gradually the effect of the drug will gradually start going away. So I have today called a suspected myasthenia gravis patient in my clinic. I've told her, ma'am, I want you to look upwards to the roof of the clinic. And when you will be requesting this lady to look upwards for as little as 30 to 45 seconds, there would be a triggering of ptosis. I'll repeat the fact once again. I said today in my hospital, I have called a suspected case of myasthenia gravis. I'm calling it suspected because the workup of this patient is still being done. And when I have requested her to look upwards to the roof of the clinic, I know that the ptosis part will be triggered. And I'll tell her, ma'am, that while you're looking upwards, I will be putting a cannula in the dorsum of your hand. Normally, if somebody is putting a cannula in your hand, you have a tendency to look down where the person is working. So I'll tell her, ma'am, please don't look down at where I'm working. Just look upwards, like not look up like this, but just look upwards like I'm doing at the movement, upward gaze. And that's when I'm going to notice that the ptosis part will start developing in this case. And meanwhile, I've secured my IV cannula as well. So I have put in the adhesive tape, the cannula is in place, and my nurse will hand me over a syringe which is containing 10 milligram hydrophonium. I'm not going to inject entire 10 milligram of hydrophonium. Out of 10 milligram, I'm going to inject only 2 milligrams of hydrophonium. And what you're going to notice is that if it's a genuine case of myasthenia gravis, the moment you inject this drug, you are gonna notice that the injection will start working after 30 seconds and the peak effect will start coming around 5 minutes. So this same patient who was having ptosis, and you can look at my eyes for a second, like it's literally shut down. Person was like literally sleepy because of the ptosis component. When you're gonna give this injection, the moment the drug starts working, you will notice the ptosis will disappear and the look of the patient will be as if he and she is staring at you. I mean, such pronounced result. Like it's gonna be like literally eyes are shut, and you ask the patient, "Are you sleepy?" She says, "No, no, sir, I'm fine. Like my eyelids are becoming heavy. They always become so heavy, and everybody calls me a sleepy head because of the ptosis component." Like non-medical people, they're saying, "Oh, are you trying to sleep with one eye?" Something like that. And you will notice the moment you give this shot, there's gonna be a very pronounced staring kind of effect coming. So he says this fact in the book that it has to be a very unequivocally positive. I mean, from a status where eyes are literally shut to a status where the person is staring in front of you. That's the kind of response that we anticipate. And though everything looks very hunky dory at the moment, everything looks very cool. The problem is that there can be a development of cholinergic crisis. And how do you pick up cholinergic crisis? There would be excessive stimulation of the salivary gland, so there would be hypersalivation. There would be, because acetylcholine values will spike at the neuromuscular junction because you're preventing breakdown of acetylcholine. I mean, adrophonium, what it is, it's basically the enzyme which is responsible for breakdown of acetylcholinesterase. So if you're gonna inhibit the breakdown of acetylcholine, then acetylcholine at the neuromuscular junction levels will suddenly spike, and therefore excessive stimulation of salivary gland will cause hypersalivation. Excessive stimulation of lacrimal glands will cause hyperlacrimation. Acetylcholine will cause frequent urination in these patients, so person will have to go to the washroom again, or they can be increased GI motility contributing to development of diarrhea. So what I'm also trying to utilize here is just remind you that when you're doing this test, you should be keeping in mind that during the performance of tensilon tests, sludge symptoms can be developing in a patient. What I mean by sludge symptoms is one, since the level of acetylcholine at the neuromuscular junction will spike, there can be hypersalivation, there can be a hyperlacrimation, there would be a frequent urination, and the biggest problem is that there would be an impact on the heart as well. The heart rate will tend to reduce in these patients because of acetylcholine levels being relatively higher. This is after all only a mnemonic. So what I'm trying to say is the G here would stand for GI motility is increased, and once the GI motility is increased, it will contribute to diarrhea. When you look at the eyes of these patients, the excessive levels of acetylcholine will cause meiosis. And then, as I said, the impact on the heart will contribute to bradycardia. In, I think, pharmacology questions, you would have read about like which parameter would be good to assess whether the patient is going into a cholinergic crisis. That would be bradycardia with hypotension. And well, the problem for me is I am trying to diagnose the condition, and in spite of the fact that the person is only in a diagnostic stage, there is a decrease in the BP and there can be a injury in a person, he or she can fall down also. See, when you're trying to do a test, you want the patient to be safe. You don't want a medical legal case. And here what you're getting is a drop in the heart rate and a drop in blood pressure, which could be a source of potential litigation. So why doctors don't want to do this test is primarily because of the fact that if somebody tries to do this test and unfortunately person aspirates on her own saliva, or she has a hypotension and she crashes, there's a high risk of her relatives suing the doctor while only the workup was being done. You also need to be ready with the antidote, that is atropine. So everything looks very cool when you read it from the pharmacology perspective that, okay, I'm going to use atropine for management of cholinergic crisis in a patient. One of the very reliable features for diagnosis of cholinergic crisis is a drop in the heart rate. But then this is like, uh, a potential time bomb waiting to explode, in a sense that if person, I mean, if everything goes well, patient is going to be thankful. Test can be done. Please don't be under impression that I'm trying to say that don't do tensilon test in patients. We do tensilon test in patients, but only in difficult to diagnose cases. He categorically says test that we're discussing at the moment, tensilon test. I mean, when would you be doing it? This test is now reserved for those cases where antibody test is negative, electrodiagnostic test are negative, iSpec test is negative. I repeat the case, when would you do a adrophonium test? It is now a backup test. It is those cases which are difficult to diagnose. The antibody tests both for anti-MuSK, anti-LRP4 and anti-acetylcholine receptor antibody tests are turning out to be negative. The electrodiagnostic tests are also inconclusive, and then they've also done, let me say, ISPEC test. ISPEC test is, in fact, I'll say a very surprising statement, which is that the sensitivity of a ISPEC test is found in clinical studies to be equal to that of penicillin test. I mean, imagine you putting ice and the symptoms are disappearing, and there is no cannula that needs to be put. There is no risk of any bradycardia, hypotension. There is no risk of any choking on self-secretion. I mean, tongue in patients of myasthenia gravis would be weak, so they can choke on their own saliva. They can be a potential risk of aspiration as well. So I don't want these problems. So tensilon test would be done only in those difficult to diagnose cases where there is going to be inconclusive electrodiagnostics, there is going to be negative antibody titers, there is a negative ISPEC test. That is the situation where you would be doing a hydrophonium test, and you have to be also ready with antidote for cholinergic crisis that can be triggered, that is atropine. I mean, the therapeutic usage of atropine that I've discussed prior to this would be mainly with respect to symptomatic bradycardia and cardiology. And pharmacology, you read about organophosphate poisoning, where again atropine is used. This slide is mainly a recap of, like, cholinergic crisis aspect that you tend to study in pharmacology. Otherwise, from medicine perspective, this does not have too much of importance, because we are talking about diagnostics, and he says that do it only in those tests where the remaining tests are turning out to be inconclusive. Then hydrophonium test can also be false positive. That's a miscellaneous fact that I would like you to remember, that false positive hydrophonium test can be seen with amyotrophic lateral sclerosis. ALS has been discussed separately with motor neuron disease topic. When you scroll through the list in the videos, you'll read about amyotrophic lateral sclerosis, where I've talked about a scientist by the name of Stephen Hawking, a very interesting disorder where combination of lower motor and upper motor manifestations are given. So considering the risk involved, considering false positivity, we keep it in a reserved state for difficult to diagnose cases. The same test in earlier times when I was a student, your age, this used to be the first test to be done. And now it is like a backup test. With advancing time, we also have to enhance our knowledge base, and we have to take into consideration even potential medical legal aspects, and then we keep on refining the diagnostic protocol. The next test that is done in these patients has been asked in the exam as what imaging modality will be done for evaluation of myasthenia gravis patients. It looks very surprising, but then why are we doing a CT test? We want to evaluate the thymus abnormalities. Remember that 75% of patients would be having a thymus issue, 65% having a hyperplasia, 10% having a thymoma. So it is for the thymus abnormalities that a CT test would be done. Then we'll be doing autoimmune panel as well. Here the question will say which autoimmune disorders can coexist with myasthenia gravis. That's again very surprising, because normally a single patient will be having a single disease, but surprisingly, myasthenia gravis can coexist with Hashimoto's thyroiditis. In fact, in some cases, they can be graves also. So, hypothyroidism and hyperthyroidism both could be associated. Obviously, both not in a single patient. We are talking about different patients, but then hypothyroidism and hyperthyroidism in different patients can be associated with myasthenia gravis. Other autoimmune disorders that can be seen are like rheumatoid arthritis, systemic lupus erythematosus. So instead of writing tests like anti-CCP antibody, anti-nuclear antibody, test for Graves' disease is thyroid stimulating antibody, for Hashimoto is thyroid peroxidase antibody. So instead of writing that separately, we have done an autoimmune panel. This would help us pick up those autoimmune disorders which can coexist with myasthenia gravis. Then workup for tuberculosis should be done, because we will be requiring steroids in majority of cases, and in fact immunotherapy is of primary importance in this condition, because B and T cells play a role with respect to pathogenesis of a disease. So if we are going to modulate the effect of T cells, if we're going to prevent the B cells from producing antibodies, it is all the way important, because we are going to modulate the immune system. So workup of tuberculosis should be done. Similarly, because steroids can cause a derangement of lipid profile, especially in India, type 2 diabetes mellitus can be present. I mean, if you give steroid, then HbA1c values will spike and diabetes manifestations will occur. So HbA1c testing should be done in our case. Plus, I'll be testing the case even for thyroid function test. That's to evaluate and supplement that okay, the person is either having features of hypo or hyperthyroidism, which also needs to be treated. The next test we'll be doing is pulmonary function testing. This is because we might be planning to do thymectomy in patients of generalized myasthenia gravis. And before thymectomy, if the FVC of the patient, the forced vital capacity component, is substantially impaired, then in those circumstances, the person would not be fit enough for surgery. See, before any surgery is done, we need to check out the lung status of a case, because post-operatively, if the lung status is not good enough, there can be atelectasis of lung segments, there can be segmental collapse, which will worsen ventilatory drive, and this disease anyway has a tendency to cause a diaphragmatic paralysis as well. So I want the lungs to be perfect before I plan a thymectomy, which is why pulmonary function testing as a baseline would be done. And because steroids can cause development of osteoporosis as well, so the textbook also mentions regarding a pre-treatment bone densitometry to also be done, so that you can monitor the person for development of side effects of steroid, especially point number 7 that I've written. TB workup, HB1C and bone densitometry are mainly with respect to immunotherapy as a baseline testing must be done, because immunotherapy and steroids would be used in these patients. The normal tendency is we always focus on pyridostigmine or neostigmine for management of this condition. But in the exam, you will notice he is not going to obviously talk about pyridostigmine, neostigmine, but he'll also focus on the role of thymectomy for patients of generalized myasthenia gravis. It does not have a role in ocular. That's again a question. I'll just enumerate that on the subsequent slide. But then thymectomy plays an important role for reducing the dose of steroids. Otherwise, steroids will cause Cushing syndrome manifestations. It will cause probably diabetes mellitus, or it will cause a diabetes mellitus type 2 to be presenting earlier than what it would usually have. And that's why it's important that we do proper workup of these persons, and then subsequently the treatment of the case can be started. Coming to the treatment part, we'll first focus on generalized myasthenia gravis treatment versus ocular, and I've already sensitized you to the fact that the difference between the two in the treatment algorithm would be with respect to thymectomy. If he says what is the drug of choice for both of them, your answer is pyridostigmine. Do not fall in a rush to the answer. He'll talk about neostigmine as well. Neostigmine has a shorter duration of action, so for babies it's okay, but for adults it's pyridostigmine. And do not rush and answer physostigmine, which has a central action. Physostigmine is in fact contraindicated because it acts on the brain. This disease does not demand a central action. This is a fat soluble drug. It crosses the blood brain barrier, and by crossing the blood brain barrier, it will be having action on the brain. Like I said, I don't need action on the brain. This is the disease of the peripheral nervous system. I need a peripheral actions. That's why physostigmine would not be required for these patients. Then the next step after pyridostigmine is causing a symptomatic relief is that person will be made aware that your thymus is the villain. The thymus was having those myoid cells which are expressing that acetylcholine receptor antigen, and the antibodies that are formed due to thymus hyperplasia thymoma are causing now the sensitized antibodies. I mean, there's an autoantigen already present, and then the antibodies are now contributing to substantial damage. So we would like you to go ahead with thymectomy. However, thymectomy will only be done if we are having a good FVC values. If the pulmonary function testing is sufficient, that's it's okay. Otherwise, in myasthenia gravis, no, there would be a reduction in the lung capacity. Residual volume of these patients might be increased because they will not be able to push air out of their lungs. So specifically from the perspective of respiratory system, you need to remember RV is increased in these patients. That's primarily because their chest muscles are not able to function optimally. Like when we try to force air out of our lungs would, we have a FEV1, we have a FEV2, but then there's a limit to the amount of air that can be pushed out of our lungs, and at the end of a forceful expiration there is still some residual air in our lungs. But in these patients, because they'll not be able to push the exact amount of air out, therefore residual volume in these patients would be increased. So if we have a good FVC, it's okay. Otherwise we will not plan thymectomy. And why are we insisting on thymectomy is that most cases can exhibit a remission after thymectomy. Most cases can exhibit a remission after thymectomy, which is why it is to be answered as the treatment of choice. If symptoms persist in spite of doing a thymectomy, then we can be using steroids. And if we give steroids on a long-term basis, they can be problems from the perspective of impaired glucose tolerance, and they can be Cushing syndrome manifestations. So even steroid sparing agents can be given. That would be in the form of mycophenolate or azathioprine. So immunomodulatory agents specifically, I mean, I'll specifically say not immunosuppression, but the word immunotherapy. We are trying to modulate the immune system. We are trying to work in tandem with the immune system, not to the level that we are depressing the immunity, but at the same time we are preventing the antibodies from attacking the cell. The advantage of a query that I get from to doctors is, if you had to start steroids, why did you not start it right away, and why did you insist first on a thymectomy? Because studies have shown that thymectomy reduces the requirement of dosage of steroids. I mean, you will, like, suppose if I don't do a thymectomy, I might be having to give 40 milligram prednisolone to the patient. On the other hand, after thymectomy, I might be requiring only 5 milligrams. So because the disease is going to be persisting for whole life of this person, as a result of it, our objective is to put the patient on the least amount of steroid that is just sufficient enough to suppress the autoimmune response. Now, coming to ocular myasthenia gravis, if he says what is the first step, we would like to do a MRI, that is to rule out the secondary cases or secondary causes which could be affecting the oculomotor nerve and can contribute to development of ptosis as well. One simple example I can give for asymmetrical ptosis is unruptured berry aneurysm, which is originating in PCOM, the posterior communicating artery, and because the berry aneurysm will squeeze the posterior communicating artery. That's why the PCOM aneurysm will press the oculomotor nerve, and that's why asymmetrical ptosis can be developing. So my objective of doing imaging is to rule out the secondary causes. The drug that will be introduced in these patients is also pyridostigmine. And while I'm writing it, I would like to remind you that pyridostigmine can be having a poor response if it is a patient is anti-musk antibody positive. I'll just jot it down in a while. The main approach, the DOC for both of them is the same. Whether he says generalized myasthenia gravis, whether he's gonna say the word ocular myasthenia gravis, the drug of choice for management of these patients is the same. But in ocular myasthenia gravis, if we are having an unsatisfactory response, if the symptoms would still be persisting in spite of giving pyridostigmine, then here the next approach which is to be given or answered is not will be answered as thymectomy. Then we'll straight away go in for immune therapy. We'll straight away start steroids. The main message from this discussion is that when would you answer thymectomy in multiple choice questions? You would answer thymectomy only per se for the generalized variety of myasthenia gravis. If he says the word ocular, then don't talk about thymectomy. Initial approaches, do MRI to rule out secondary causes, give pyridostigmine, and then straight away go to step number 3, which was written for usage of steroids. So the immunotherapy, I mean, he's not using the word immunosuppression, he's using the word immune therapy, is the one that we'll be using, because lots of time we have access to monoclonal antibodies also. Like they can be monoclonal antibody like eculizumab that can be used in these patients, which will help in depleting the B cells, and B cells are the villains which are ultimately causing differentiation into plasma cells, which are causing antibodies that are attacking cells. So what are the drugs that are used from immune therapy perspective? We'll be using glucocorticoids. Let me just jot down glucocorticoids. Glucocorticoids should always be given as a single dose, least possible dose which will cause sufficient amount of immune modulation, just that the symptoms will tend to minimize. I mean, that's the dosage which is to be given. It should be given as a single dose to minimize the risk of development of Cushing syndrome. In case we are forced to use steroid sparing agents, then what are the drugs available? We have mycophenolate, then even monoclonal antibodies like rituximab. Like traditionally, rituximab is read by us with monoclonal antibodies, but then the role of this has expanded even in the kidney part. We read about rituximab being used for management of membranous glomerulopathy, or like other monoclonal antibodies, eculizumab. And the last time I've talked about eculizumab usage is with respect to neuromyelitis optica. I mean, in neuromyelitis optica, NMOSD, where I've described bilateral optic neuritis, I've said eculizumab is useful. So earlier we used to read about eculizumab specifically in paroxysmal nocturnal hemoglobinuria, PNH, Then we started reading about in neuromyelitis optica and even in management of myasthenia gravis patients. But as a steroid sparing agent, I mean, we'll try to give the cheapest treatment available to our patients at the least possible dosage. But then backup drugs are also to be kept ready, and it does not use the word immunosuppression, though in the table in Harrison is written suppression, but in theory is highlighted the fact. So, I mean, that's a slight disparity. If you read the table of Harrison, it is written immunosuppression in myasthenia gravis topic. And if you read the data subsequently is written immunotherapy, he says it's recommended to use the word immunotherapy. That's primarily because we are trying to modulate and just suppress the manifestations. As far as myasthenic crisis is concerned, though talk has been done about it also, myasthenic crisis, most of the time, the most common trigger, I mean, the triggers can be multiple, ranging from pregnancy, but the commonest trigger that is responsible for myasthenic crisis should be answered as intercurrent infection. This could be COVID-19, it could be urinary tract infection, it could be a walking pneumonia like a mycoplasma pneumonia episodes that occurred in the winter of 2023 in China. So the point is, all of these patients should always be sensitized about this fact that since you are on glucocorticoids, you need to, especially if you're going out in a crowded place, try to use a mask, or at least teach them about the aspect of barrier nursing so that they can reduce the chances of their deterioration. In myasthenic crisis, we will be using intravenous immunoglobulins, we'll be using plasmapheresis. In fact, you will notice that the requirement of steroids will suddenly increase once the person goes into myasthenic crisis. When do we say myasthenic crisis? When ventilator requirement is there or ventilatory support is required, the buildup of carbon dioxide can cause CO2 narcosis. The PO2 values will begin to reduce, and therefore myasthenic crisis should be remembered as an example of type 2 respiratory failure. I'm not writing it here because in the types of respiratory failure, I've catered to that. But then myasthenic crisis is an unfortunate complication that can occur and can even cause demise of these patients. We shall now be comparing this data with Lambert-Eaton syndrome, which happens to be pre-junctional defect. Let's take this to be a representation of a nerve. At the distal end of the nerve, the white dot that I've shown is calcium channels. And every time the calcium channels will open, there is going to be release of acetylcholine, which I've shown in the form of these red dots. Let's say these 6 dots are representing 6 million molecules of acetylcholine, and these would be acting on the postsynaptic cleft. In this postsynaptic cleft in blue, I've shown receptors. So there are a lot of them on which this acetylcholine, abundant receptors on which this acetylcholine can go and bind, and the muscle will be able to contract. The acetylcholine molecule, which is shown in color red, will be acting on the alpha subunit of the receptors shown in blue, and therefore sodium entry will occur into the muscle and the muscle will be able to contract. Now what happens in Lambert-Eaton syndrome is, unfortunately, that our patient is having a lung cancer, that to one of the most aggressive lung cancer, that is oat cell cancer, and this lung cancer is producing antibodies. The name of these antibodies have to be remembered. Most guys tend to forget it. The antibody in Lambert-Eaton syndrome is called as anti-PBQ antibodies. Where are these antibodies gonna act? Then these antibodies are gonna cause a partial closure of the voltage gated calcium channels. I repeat my statement once again. These voltage gated calcium channels were responsible for acetylcholine release, and now because this antibody is gonna attack these voltage gated calcium channels, therefore there's gonna be a development of partial closure. I'm putting a line over this to say that the calcium channels that were now previously working properly and they were open, now there's going to be a partial closure, and because of this partial closure of these calcium channels, the amount of acetylcholine produced at the neuromuscular junction will be lesser. You can see that I'm erasing some of the red dots here. The reason I'm erasing them is because the moment the antibody will attack these calcium channels or affect these calcium channels, there's a partial closure, and therefore the amount of acetylcholine at the MJ and MJ will reduce, which explains the fact that the first statement that I made for Lambert-Eaton syndrome is that it's a pre-junctional defect. Because it's a partial closure, it can also be overridden by exercise. If you are going to do a high frequency stimulation, this partial closure can be suppressed, and rather the channels will open once again, and therefore incremental response would be seen, which is one of the key words in questions of Lambert-Eaton syndrome. Let's see how the question will be given on this topic. He'll most of the time describe a smoker. He'll describe this guy, he has been having cough, and in India, anybody is having cough for more than 3 weeks, you start thinking in terms of TB. So maybe initially the workup for TB was done, but because there was substantial weight loss occurring, and then he had maybe hemoptysis, so initially we thought TB, but then the workup of this patient showed probably development of a lung mass, which is contributing to antibodies, and that's why this guy has come to you for a consult. It's a presynaptic defect. This presynaptic defect decreases the amount of acetylcholine at the neuromuscular junction. Why? And as a result of it, the manifestations will occur. Hence, the question in this topic will most of the time begin by describing a 50 to 60-year-old guy who will mostly be a smoker. As you know, that smoking is associated with development of small cell lung cancer, which is one of the most aggressive lung cancers. The commonest lung cancer overall is adenocarcinoma. But the one that tends to show micromets, and the aggressive one which goes to the brain, goes to the heart, is small cell lung cancer, which is playing a spoil spot today as well. And well, the first thing to be remembered for this condition is that MCQ will describe proximal limb weakness. Most of the time, shoulder girdle weakness or hip joint muscle weakness could be described. And along with this, he will also talk about ptosis. There is a high probability that the moment you start reading about ptosis and development of diplopia, you might be tempted to think in terms of myasthenia gravis also, because even there I was saying the same data. But one of the key features that would help you in differentiating would be that the reflexes in this condition will be given to be absent. Though I sensitized you to this data even earlier, but that is a good pickup point. The first feature of this condition would be a proximal limb weakness. You see, when I was describing myasthenia gravis, I began with diplopia and ptosis. Here I mentioned diplopia and ptosis after proximal limb weakness. But the point is this: point number 1 and point number 2, there's a probability that in the exam, the way he's writing it, you may not be able to pick up or remember instantly that, okay, which is the first manifestation described, because he's going to describe these at two different lines in the question. And one line is talking about limb weakness, other line is talking about ptosis. So it becomes a little difficult to, comprehend that which disease among the two is he trying to talk about. So yeah, I mean, it's obviously important that ptosis will be written first in MCQ myasthenia gravis, and proximal limb weakness will be written first in patients with Lambert-Eaton syndrome. But there's a probability that you may skip this data. But areflexia as a feature would help you. Then other features that can be described in a question would not be seen in myasthenia gravis. That's gonna be even autonomic involvement. So he's gonna talk about dry mouth. He can talk about inability to have an erection or development of impotence, and those kind of features would not be described with respect to myasthenia gravis in a male patient. Then the fifth point is one of the important discriminating feature in multiple choice question, where you'll talk about repetitive nerve stimulation. And listen to my words very carefully. This point that I'm saying, wo janbooch ke bolega, that when low frequency stimulation of the muscle was done, there was a presence of a decremental response, and there is a high probability that on reading this data, you might straight away answer it as myasthenia gravis. You see, when you are gonna do a high frequency stimulation of the nerve, that is between 25 to 50 hertz, that is when you are able to see a incremental response. If he straight away will write incremental response, it would be a piece of cake for you. So to trouble you in the exam, there is a probability that while describing repetitive nerve stimulation, he might mention decremental response at low frequency. But if it's gonna be post exercise, or if it's gonna be 25 to 50 hertz stimulation, then you are gonna see a incremental response. So keep that point in your mind, that decremental response can be given in MCQ Lambert-Eaton syndrome also. But then in the same patient, if we increase the frequency, incremental response is seen, whereas the same kind of description would not be seen with myasthenia gravis. When I say that, the query of most people is, sir, why the differentiating factor? Well, the differentiating factor in myasthenia gravis, post-junctional receptor is damaged, and if post-junctional receptor is affected, then I can't do anything. If there's flattening of the postsynaptic cleft, you can't do anything. You can't go be God and make the receptors come back. You cannot change that flattening of the postsynaptic cleft. But in pre-junctional defect, acetylcholine amount is lesser, so I can increase that acetylcholine amount being released. I can increase the quanta. See, post-junctional, you can't do anything if the weakness part is there. You can't do anything in a sense that repetitive stimulation will not work. Even if you increase the amount of acetylcholine in high frequency stimulation, amount of acetylcholine at the neuromuscular junction of myasthenia gravis will increase. But will it be able to act? Absolutely no. But in this condition, it will be able to act. Why? Because the receptors are just fine. If you look at this diagrammatic representation, that is what I was trying to say. There's a partial closure of the channels. If we are going to do a stimulation again and again, they will reopen once again. They were not destroyed. I just said the word partial closure. There's a possibility of reopening of them as well, upgrading the acetylcholine amount, and the receptors are very much fine in Lambert-Eaton syndrome, in contrast to myasthenia gravis, where the receptors were affected. So point number 5 is a highly, discriminating feature from an MCQ domain. And now we'll focus on the treatment for Lambert-Eaton syndrome, where we can be using pyridostigmine as well. But the first answer of yours for management of this case would be answered as 3,4-diaminopyridine. And well, how this works is, you have to remember the technicals here. It acts by blocking potassium channels, and a bit of physiology in this case that I'm bypassing. But what I'm trying to say is that blocking potassium channels again causes an increase of amount of acetylcholine at the neuromuscular junction. After all, our objective is to increase the amount of acetylcholine neuromuscular junction by hook and crook. What I mean by hook and crook is, either I can increase it with help of drug support, or I can increase it by making the person exercise, or I can increase it with a high frequency stimulation. So this time we're using a drug to bypass the pre-junctional deficit of acetylcholine at the neuromuscular junction. So 3,4-DAP, diaminopyridine, would be used for management of this condition. And then apart from this, even plasmapheresis plays a role. In fact, plasmapheresis, I was not very vocal about with respect to myasthenia gravis. I mean, in crisis, it's okay. I mean, plasmapheresis in crisis is okay, but then routine myasthenia gravis, we are not going to use plasmapheresis, but has been shown to clear the anti-P/Q antibodies in Lambert-Eaton syndrome. Then pyridostigmine will be used in both of them. The mechanism of action of pyridostigmine is mainly going to be that it will inhibit the breakdown of acetylcholine, and if you can increase the amount of acetylcholine, duration of action at the neuromuscular junction, again the power of the muscle will increase. See, first thing what I'm doing is I'm increasing the amount of acetylcholine, and after increasing the amount of acetylcholine in the neuromuscular junction, the second thing that I'm doing here is that I'm also increasing the total duration for which acetylcholine is being able to act. Over and above this, I would also like you to remember that botulism, most of the time for botulism, the aspect would be that honey was given to a baby after birth, and therefore they would be germinating the spores of, because the honey was poor quality. So the botulinum spores will germinate, botulinum toxin will be produced, and it will cause a floppy baby. He'll not be able to breastfeed. The total body of the child will become very limp. There would be autonomic features also. But from the repetitive nerve stimulation perspective, again for botulism, you need to remember that if we do a high frequency stimulation, that would be 25 to 50 hertz stimulation, we again get an incremental response. So today I've described two conditions of repetitive nerve stimulation where in the exam incremental response would be given: Lambert-Eaton syndrome versus botulism. Botulism would be seen with respect to only two possibilities. Either in India, it would be like a newborn baby and poor quality honey was given, or somebody's eaten meat of extremely poor quality. Like these guys went out for hunting in the wild bush of Australia and they're eating kangaroo meat. Now they shot the kangaroo, then they went to kill a couple of more kangaroos. By the time they go back, 6 hours had passed by. And in a hot Australian desert, at in that heat, the meat is gonna degenerate very fast. And then these guys are eating that. I mean, this happened recently. If you there was an Indian family who were living the Australian way and they were eating this kangaroo meat, and they had this kangaroo meat and the whole family died because of botulism. This was in the news. You can Google this. Indian family dies after eating kangaroo meat while on an Australian holiday. So the botulism part would either be with respect to poor quality meat or would be like poor quality honey. So it's going to be food poisoning basically. And there's going to be autonomic manifestations, like there's going to be paralytic ileus, urinary retention, constipation, dilated pupils, dry mouth. So autonomic features, I would say, autonomic features would be described with respect to botulism, but our main focus is like decremental response in myasthenia gravis. Whether you do low frequency or high frequency stimulation, nothing is gonna change. वो change होगा नहीं, because acetylcholine will not be able to act even if you increase the amount. But in pre-junctional one, because there's a deficit of acetylcholine, so high frequency stimulation causes a more quanta of acetylcholine being released, and thereby is gonna show an improvement. So these are the details that I would like you to remember for this topic. Keep the pressure on, keep hammering, keep learning new facts, and you're gonna be much more wiser. And your strike rates are gradually gonna get a lot of messages saying that neurology is exhaustive. It takes a a long time to finish the videos, but believe me, the end result is going to be worth the effort and the hard work that you guys have done. Thank you.